Hello, and welcome to the Bigg Elimination Tribute Project for building provider capacity for hepatitis C prevention program integration. We will be starting Module 1A about prevention and education for the undiagnosed. Each of these modules are built as standalone modules and will follow the same structure throughout. My name is Jill Wolf. I am the Hepatitis C Program Director for the Caring Ambassadors. This project was co-created in October of 2019 with the Chicago Recovery Alliance, also known as CRA, and it has been adapted for a web-based, self-paced module training. We are grateful to our sponsors for the support to do this training. As the name of the project indicates, this project is in honor of Dan Bigg, former Executive Director of the Chicago Recovery Alliance, a fierce hepatitis C elimination advocate and harm reductionist, and a good friend of the Caring Ambassadors. It's with his spirit that this project was made and continue to be adapted to impact communities across the world. The overall goal of this project is to build your capacity, confidence, and knowledge to integrate responsive hepatitis C screening, testing, linkage to care and cure, and support programs into your existing infrastructures. The training follows a 7-module series, and we will be beginning today with 1A under prevention and education, followed by screening and testing, vaccination, staging, treatment, cure, followed by wellness and support. This structure is ultimately based on what I wish I would have known when I worked within addiction treatment services back in 2010 to 13. Just prior to me joining the Caring Ambassadors program. So this is ultimately what I wish I would have known. Many of you may have heard this saying, nothing about us without us, or nothing for us without us. This is a harm reduction concept and spirit that ultimately includes the lived experience of people who are most impacted. And in this case, we're working with harm reduction, and we're working with hepatitis C and viral hepatitis. And so in the development of this project, we collected stories from those who are most impacted. And the way that each module will work is at the top of the series, we will hear from our constituents on their thoughts. But we're going to first start with introductions so you can see who we will be hearing from throughout the series.
My name's Luke Tomsha. I'm from rural central Illinois. I was a heroin user, injection heroin user for over 14 years. And I've made it my purpose in life to share my experiences and really be a voice for those people that don't have voices. So that's who I am, and that's where I focus my work these days.
And just to mention, Luke didn't say this here, he works for the Perfectly Flawed Foundation. We encourage you to look them up.
My name is Peter McLoy. I'm the Consumer Development and Advocacy Coordinator at the Ruth M. Rousing Core Center. My work includes working and supporting our peer educator program, as well as doing a lot of policy work here locally as well as nationally, and keeping our leadership informed.
Tell me a little bit about yourself, Peter, outside of your work here at Core Center.
Well, I think the thing that brought me to CORE was I was diagnosed with HIV in 1997. I'm a recovering drug user. My drugs of choice was heroin and cocaine. So I came here with an active habit of heroin. I had gotten real sick and was hospitalized at the old Cook County Hospital. And so it was quite a shock to me finding out I was HIV positive.
My name is Juanita Dupre. I'm 68 years old. And just an old grandmother here with some problems that I'm trying to fix.
Oh, yeah?
Trying to fix.
Tell me about a couple of those.
Well, I've had a drug problem since I was about 17. When I started 17, I've been off and on with the drugs. I've been off and on with programs. I was clean for 4 years, but I relapsed, Now I'm in another program, But I'm not saying that I'm the greatest person. I do relapse every once in a while, but I'm still in the program trying to clean my act up.
Hi guys.
Hello.
Introduce yourselves for me, will ya?
My name is Tom Skellig. Welcome to MBAC Tonight. My name is Alex. I work with a small nonprofit called Live for Lolly. I am in recovery from heroin use.
Hey Alex.
My name is Laura Fry. I'm the Director of Patient and Family Services for Live for Lolly. I am also a person in long-term recovery and his mother.
So you've met before is what I'm gathering.
I've seen her around the table a couple times.
So I want to thank Luke and Peter, Juanita, Alex and Laura, who you'll be hearing from throughout the training. So let's jump in here. Module 1A, we're working with hepatitis C prevention and education for the undiagnosed. And the purpose of this module is to establish a replicable framework for hep C prevention and education programs, including risk and harm reduction strategies. You will be able to define the word syndemic and its relationship to hep C and opioids. You will be able to interpret the similarities and differences between hep A, B, and C and HIV. You'll be able to describe the impact of hep C, including mortality, prevalence, and surveillance. You'll be able to identify opportunities to leverage existing tools, resources, and programs to include hep C prevention services into your existing infrastructures. You'll be able to develop an action plan to amend your current programs and services to include hep C prevention programming. And you'll be able to list programmatic action steps that you're going to take to address hep C and drug-using behaviors using harm reduction strategies. So let's jump in. We got a lot to cover to ensure that you know all those things and objectives and able to meet them. An important model that we use here to address viral hepatitis in general is the concept of syndemics. And according to the CDC, a syndemic is a synergistically interacting epidemic. And the idea here is that you have disease 1 or maybe epidemic 1 and disease 2 or epidemic 2 that interact to cause additional adverse consequences. And these adverse consequences could be enhanced diseases themselves or additional diseases or epidemics, progression toward additional negative health outcomes. So this is an important model to address within viral hepatitis specifically, because it is a issue that is not funded at the level of the to the level of the burden in which it's required to fully eliminate, in this case, hepatitis C. And so I want to flesh this out using examples. We've got 3 examples here that I'm hoping will help to illustrate syndemics for you. So we're going to start with hepatitis A as the example. And we've got an epidemic or an issue of homelessness. We also have an epidemic or an issue with access being a challenge, and access to sanitary conditions or access to healthcare and vaccines in general. And these 2 things will interact to cause adverse consequences. And in this case, hepatitis A outbreak. Maybe you heard just a couple of years ago, I know that in California, there was lots of press coverage about this, but the cost of a single hepatitis A outbreak, which in this case was upwards of about 250 people, was about $1.9 million that included lost revenue, lawsuits, legal fees, fines, and medical costs. And so the idea here is that had we been able to address homelessness or even access to vaccination issues, we probably would have prevented this outbreak from happening in the first place. Let's go on and take this a little bit further. But this was from data between 2011 and 2014 in Kentucky. And what we saw in Kentucky and what we see, there's certainly opioid use disorders and overdose and overprescribing of opioids happening. And those kind of, that issue or epidemic in itself interacts with what's going on in Kentucky, which we see a lot of, again, access issues to treatment or services, stigma around substance use disorders, and poverty. And these 2 things will interact to cause additional adverse consequences. And in this case, we saw the rise in hepatitis C among childbearing women increase between 2011 and 2014. Nationally, we saw an increase of 22%. But in Kentucky, we saw an increase of 213%. And as you probably guessed, the way syndemics work is that we will likely have another issue here, and we are seeing another issue, of the rise in babies born to women with hep C. Nationally, between 2011 and 14, we saw an increase of 68%. And in Kentucky, we saw an increase of 124%. So naturally, this causes us to work with other additional issues, and prevention-related programs are needed to work, in this case, with women of childbearing age and children born to hep C positive women. Let's work with our last example here. For those of you who work in HIV, this is probably familiar to you. We're going to talk about Scott County, Indiana, which is where in, was it 2015, there was an outbreak of HIV. And what we saw there was opioid use disorders and overdose and overprescribing. In that particular case was with Opana. And it was combined with stigma and poverty. And there was certainly the war on drugs was impacting that state and that then governor who would not allow needle exchange programs or harm reduction programs. And there was naturally a transportation issue with rural America. And here's what happened. We saw in a county that the decade before this had about 5 to 10 HIV cases. There was these 11 initially identified confirmed HIV cases that sparked this investigation. Now, what's important to understand here is that the disease intervention specialists and the epidemiologists and the public health professionals were letting the public health department and the then governor know that there was a challenge coming down the road here. But as you could probably guess, the then governor didn't pay attention, which landed us with this outbreak. And there was an identified of 215 eventually, once this 11 confirmed cases were found that sparked this investigation, they found upwards of 215 HIV positive people within this 4,200 person county. And what they found that there was a 92% co-infection of HIV and hepatitis C, and that ultimately Indiana spent about $16 million through August 2015 to stop this outbreak in one county. There's a few things we need to talk about here, which is that because of the way the United States public health system works, this information is through an HIV lens. Because of the Ryan White CARE Act, which affords us the opportunity to do HIV prevention and disease intervention, all of these elements, we were able to go into Scott County and actually address this outbreak. So it's important to remember this is through the information we have is through an HIV lens. But I also want to contextualize a little bit more what this outbreak actually meant. And in Scott County, where they found this upwards of 215 people, Scott County, Indiana now has a higher HIV incidence than any country in sub-Saharan Africa. This is huge. And even to put it in a different perspective, there were more people infected through injection drug use with HIV than in all of New York City in 2018. And so again, this is really important when we talk about leveraging the existing dollars in a syndemic approach to quell additional diseases such as this. So hopefully you understand syndemics and able to see how things interact to cause additional outcomes. We're going to jump into hepatitis and ensuring that you understand what this is. And we'll get into a little bit more about hepatitis A, B, and C. So hepatitis is ultimately a term that refers to liver inflammation. Hepa means liver and titus means inflammation. And it's an umbrella term used because ultimately there are many things that cause liver inflammation, such as toxins and medications. And as you'll see here, hepatitis A, B, C, D, E, all the way through G. Now, besides, I would not recommend you get this umbrella because clearly it's not doing a great job of keeping these raindrops from coming underneath. But hopefully you get my idea that all of these things contribute to someone's liver being inflamed. And because our liver is our body's filter, and anything or everything we eat, drink, put on our skin is filtered through our body, you can see why alcohol or medications, toxins might cause liver inflammation, especially if it's in the presence of an additional virus that someone might have. So hepatitis A and B, you'll see here, are vaccine preventable. Hopefully all of you have been vaccinated. And we have additional hepatitis. You might not have heard of D or E, but ultimately they do exist. Hepatitis E comes from swine. And some of these are more super infections, like I believe hepatitis D you can only have if you have hepatitis B. But the idea here is to understand just that liver inflammation is caused by many things. So let's further flesh out here the difference between the A and the B and the C of hepatitis. And we're going to start from top down. In terms of hepatitis A, it's transmitted through fecal oral. Now, you may have heard of this as restaurant hepatitis. I've heard people use that term. And ultimately, what this means is that you've eaten or drank something that was contaminated. In this situation, somebody who had hepatitis A went to the bathroom, didn't wash their hands, maybe they prepared your food, or you were drinking water that had hepatitis A in it, and that is how you would then come into contact with it. As you'll see, 0 people develop chronic infection. The way that Hep A works, if you get it, you'll get sick and up it's over. So nobody goes on to develop chronic infection. But what if you did have it, you would be immune after infection. There is a vaccine, and the cure, we say that this is a self-limiting virus. And so what that means is that you may get sick, you probably will. A very, very small percentage of people actually die from a hepatitis A infection. And so there is a cure, we would treat that. And because of the vaccine, or if you were to become infected, that would mean help build your immunity to this virus. So hopefully you won't ever get hepatitis A because you've been vaccinated. Hepatitis B is transmitted through blood and other bodily fluids. It's highly infectious. For adults, if an adult were to come into contact with hepatitis B, between 6 and 10% of them would go on to develop chronic infection. Now that's with adults, and it's opposite. We'd flip that for infants and children. So about 90% of infants who are born with a hepatitis B positive mom, if they are not vaccinated at the time of birth, they will have 90% chance of developing that chronic infection. There is immunity after infection. There is a vaccine, but there is not a cure. And so some people will get it and clear it themselves. Others who do have chronic infection, we end up just treating the virus and the symptoms. There is no cure for it. Hepatitis C is transmitted only through blood. So the blood of someone who has Hep C has to get into your bloodstream. About 75 to 85% of people who come into contact with hepatitis C will develop chronic infection. So that's to say about 25% of people who come into contact with the virus would do what we call spontaneously clear the virus from their body. I'm not exactly sure why that is from genetics and other variables. Some people can clear it and most do not, and they'll develop infection. Now what's different here between with C than A and B here is that you do not have immunity after infection. So that means if you get it and you're one of those lucky 25% and you clear it and you do not have chronic infection, it means that you can get reinfected. You can get it again. There is not yet a vaccine, but we do have a really great cure. As of 2014, there have been what we call direct-acting antivirals, DAAs, and those have been extremely effective in curing people of hepatitis C. So hopefully you'll understand here the difference between A, B, and C, and understanding that you or your clients would and should get A and B vaccinations and hepatitis C testing and cure if you are living with chronic infection. Let's get more specific now to Hep C. We understand that Hep C is a bloodborne virus, so it lives in your blood, but it attacks your liver, and it attacks your liver cells. This is the largest chronic infectious disease outbreak of our time. And it's really challenging because most people who have it don't know that they have it because the symptoms are quite benign. Hepatitis C really doesn't let you know that it's there until something is really wrong and your liver is really sick. And the symptoms that I often hear from folks is fatigue and tiredness. And what I know is that I don't have Hep C and I'm tired many days of the week. Many people wouldn't otherwise think that these benign symptoms mean something. Now, there's very easy and inexpensive tests that can let us know if you've been exposed or if you have it. And what's important about someone getting tested is that if the Hep C is living in their body and we don't identify it, this Hep C will wreak havoc on the liver. So you'll see this is your healthy liver here with a boxing glove. And that boxing glove is using your liver as a punching bag. And the boxing glove is Hep C. And over time, This hepatitis C is beating up your liver, and it's going to cause liver damage and eventually cancer. And we know that liver cancer is one of the few cancers on the rise. And what's really, really challenging about that and really difficult to swallow for those who have developed liver cancer is that there is a cure for hep C. And had we diagnosed that person early enough, had we cured them or treated them, most likely they would have avoided hepatitis related, hep C related liver cancer. I'd like to credit Dr. Don Jensen for this slide. It's adapted a little bit, but I got it from him. And this shows hepatitis C over time. So you see here, we've got that boxing glove and the liver. This is the time of hep C infection. And your liver looks really happy. And over time, hepatitis C is going to beat up your liver and you will develop chronic infection. And over the course of about 20 to 25 years, for someone who is not co-infected with other comorbidities like maybe fatty liver disease or hep B or HIV or alcohol use disorder, for those people who don't have comorbidities, it'll take about 20 to 25 years for that hepatitis C virus to wreak havoc enough on your liver to cause cirrhosis. And cirrhosis is an additional disease caused by, in this case, untreated hepatitis C. So not only does this person have hep C, but now they also have cirrhosis, which is not a curable disease. And we'll see over 25 to 30 years, once someone has cirrhosis, they'll go on to develop HCC or hepatocellular carcinoma, liver cancer, ESLD, which is end-stage liver disease, and eventually death. So you'll see why it's so important that we're able to catch the disease early enough and treat someone early enough before they develop cirrhosis and liver cancer. And we're seeing what we're calling a bimodal distribution of hepatitis C amongst baby boomers and amongst younger folks. And there's ultimately what's interesting as a public health social commentary are the reasons that these two groups have hep C. And ultimately there's pretty different reasons, and we could maybe even say epidemics, that have caused this bimodal distribution. So we're going to start with the baby boomers. These are folks who lived at a time where hepatitis C lived in our blood and tissue supply. It wasn't until 1989 that we actually were able to find out that hepatitis C was hep C. Before that, and maybe you've heard from some of your clients that you work with, it's called non-A, non-B hepatitis. For a really long time, hep C lived in our blood and tissue supply, and we didn't know it. But it wasn't until 1992, I believe, that we had a good enough test to identify hep C in the blood supply. And so these baby boomers, which we identify are people born between 1945 and 65, it actually goes a little bit further. I'd say even 1940 to 1970. These folks lived at a time where hep C was in our blood and tissue supply. It is no longer in our blood and tissue supply. And that we didn't know what we didn't know. Universal precautions didn't exist at this time. People, especially if we think of the hippie generation and culture, lots of drug sharing and drug use experimentation. So this is a population that likely has been living with hep C for decades and not knowing it. Baby boomers hold the largest burden of hep C positive folks, and likely because they've been living with hep C for so long, they've advanced into advanced fibrosis or even cirrhosis. And so we need to really watch out for liver cancer risks and work on preventing that. These are also groups of folks who lived at a time where their old treatments before 2014 were really difficult and really hard. They may have even heard of their friends committing suicide because of the interferon and the ribavirin that is no longer used. These horror stories are stuck for these folks, and they are unaware very likely that new treatments exist that have none of those same side effects. But I'd also like to say, and this speaks to ultimately institutionalized racism and isms, these are also many folks who've been told from the past, from their doctors, that either they're not sick enough to get the new medication, or they're not sober enough to get the medication. And so this is something that certainly would deter someone from coming in to get treated. But these folks are the sitting ducks who have been living with hepatitis C for so long that they very likely will be aging into time of cirrhosis and liver cancer. So this is our first group of folks who have hep C. And now we have our younger groups. And this younger group is about 18 to 39, and we're seeing an increased transmission in people who use drugs, PWUD. As I showed with that syndemic Kentucky slide, we're seeing this impact on women of childbearing age, and therefore more children who are born to mothers who have hep C. And vertical transmission from mother to child is certainly a risk. We see that there is this direct relationship between opioids and heroin use and substance use disorders. And the ways in which we're able to currently, especially given the way in which our country is addressing heroin and opioids and drug use, we're able to sort of see and look at how this is fleshing out in terms of infectious diseases. Provider bias for diagnosis and testing. There are many providers who don't test people because either of their own discomfort of discussing the topic or because they have a bias around who they think has hep C and someone doesn't fit the bill. And this is a perfect opportunity for us to integrate prevention of infectious disease transmission amongst these folks. So this is who's living with hep C today. So let's move on to comparing HIV and hepatitis C. Many people, because our country has done such a beautiful job as a result of the Ryan White Care Act of 1990 to integrate prevention, treatment, and support for those living with HIV or at risk for it. And so many of us know how HIV is transmitted. Many of us don't know how hep C is transmitted. So what I want to do here for you is be able to highlight where hep C and HIV are similar and different. And unlike HIV infection, hep C infection, as we talked about, can be eradicated or cured from the body. So I want to focus on a couple key things here, which is the genetic archive, therapeutic goal, and cure. And I do want to say here, as a social worker, I want to give you this in the most laypersons of terms. So this is not a scientific explanation on RNA or DNA viruses, but I'm going to break this down for you in the way that I like to understand this. So as you can see here, both HIV and hep C are what we call RNA viruses. And I'm not going to go into the viral dynamic of how HIV works, but eventually, once HIV gets into a human body, it ultimately it turns into a DNA virus. It gets inside the nucleus of a cell. And so the reason, as you see here, we are not able to cure HIV yet is because we haven't figured out how to get on the inside of this nucleus. Where hepatitis C, as you see, is curable because it's an RNA virus and stays an RNA virus. Once it enters the human body, it does not penetrate the cell. It does not penetrate the nucleus of the cell. It sits on the outside of the cell. And that is ultimately why we are able to cure someone of hepatitis C, but not HIV. So you'll see here, there is no genetic archive made on this hep C RNA virus, but there is a genetic archive made from the HIV that eventually becomes a DNA virus. The difference with the therapeutic goals, HIV, our goal at this point, because we don't yet have a cure, is lifelong suppression. We want to make sure that there's low virus and that the high CD4, whereas with hepatitis C, our therapeutic goal is to clear hepatitis C virus from the plasma and therefore the liver so that we can cure them. So those are the main differences that I wanted to point out, especially for this lecture for HIV and hep C. This is little HIV, but you'll see here we have hepatitis B, hepatitis C, and HIV. And I thought to myself, and I ended up doing a little research based on this thought, but I thought to myself, okay, how infectious are these viruses that we so often talk about in public health care? And I thought to myself, in one drop of blood, if one drop of blood was infected and contaminated with hepatitis B, hepatitis C, and HIV, and if I were to come into contact with that drop of blood, what would be the likelihood that I would transmit any of these three viruses present? We're talking about virulence here, how virulent or infectious are these viruses. So if I were to come into contact with hep B, I would have a 30% chance of transmitting hepatitis B if that contaminated drop of blood were to enter my bloodstream. I would have a 1.8% chance of transmitting hepatitis C, and I would have a 0.03% chance of transmitting HIV. Now, when I first learned this actually really surprised me. And it surprised me because of the public health efforts and financial investments we put in our public healthcare system to address and prevent and quell some of these viruses. And so I thought to myself, okay, well, clearly I would more likely be infected with Hep B than HIV if I came into contact with this contaminated drop of blood. And I was like, well, okay, well, then there's more people with Hep B. And so to put this into context for you, worldwide, you'd probably assume that there's more people with Hep B than there are HIV or Hep C in the world, and you'd be correct in that assumption. There's about 240 million people worldwide with Hep B. There's about 130 to 150 million people worldwide with Hep C. And there's about 36.7 million people in the world with HIV. That's pretty powerful, right? Especially if we look at prevalence and how, at least in the case of Hep C, we could eliminate this from the blood supply and no one would ever have to face liver cancer or hepatitis C. The other thing I want to put into context, obviously there are more than ultimately 5 times as many people with Hep C than HIV and even more with Hep B, but I have to look at the public health infrastructure of our country and where our funds are put and distributed so that we can help to quell these infectious diseases. And in 2017, our HIV budget within our country, and this is total from all of the different departments within our government, was about $32 billion with a B, billion with a B, to address and prevent, treat, and support those folks with HIV in the United States. So the way our country and our public health system addresses viral hepatitis in terms of A, B, and C, which is mostly what we see in the United States, is that we have one division. We have the viral hepatitis division. Funding and services for the Hep A, B, and C are put under one umbrella, and those funds in 2017 were about $39 million, with an M, million, dollars to address viral hepatitis. And when we look at the sheer numbers, when we look at virulence, we really have to ask ourselves, how can we use the $32 billion with a B dollars that is awarded to HIV prevention? How can we use that to help quell really infectious diseases like Hep B and C when their own Hep A, B, and C are only given $39 million from our government to quell the impact? Really necessitates endemics. Now let's talk a little bit about mortality. What I want to point out here, we have green line is HIV. Deaths related to hepatitis C are in this blue line, and deaths related to Hep B is this purple line on the bottom. And we'll start with Hep B. And you can see it's mostly straight, it's gone down a little bit, thank goodness. And this is ultimately because of the public health intervention of vaccinations. Vaccination is a powerful intervention to help quell mortality. Let's try to find a vaccine for Hep C and HIV, certainly. And we'll see here that deaths related to hepatitis C surpassed that of HIV in about 2006. I want to put this into a little bit further context that in 2008, drug overdose deaths surpassed auto fatalities as the leading cause of accidental death in the United States. And so while it's not an infectious disease and we wouldn't put a line here, deaths related to opioid overdose would certainly be way up here. What I want to show with this is, certainly you don't need to look at all of these individual conditions listed, but this is the 2018 list of nationally notifiable conditions. The federal government has said that within state departments of health, if someone, a physician, a federally qualified health center, comes across any of these infectious diseases or rather notifiable conditions, they need to be reported. There's about 60 here. You'll see some of them are listed twice, like Hep B acute and chronic and perinatal and the rest of them. But there's about 60 here. And I'm showing you this because in between 2003 and 2013, the annual number of deaths related to hepatitis C surpassed that of all other nationally notifiable conditions combined. So in that other slide before that I just showed you with all those conditions, if we took away Hep C and we combined all the deaths related to the 59 that are left there, the deaths related to Hep C would still surpass those. And this is really powerful when we look at how much money is not allocated to support Hep C prevention, the impact of drug-using behaviors on Hep C acquisition and transmission, and it speaks to the necessity of addressing public health related issues through a syndemic lens. So we're going to end Module 1A on this slide here. We're talking about continuums and cascades. And what's really important here is that I'm asking you to integrate programs for hepatitis C into your infrastructure, which might be a little bit tricky, and here's why. Many of you work within continuums of care, and continuums of care are ultimately something that people would continue to be on. We think about this for someone who's got, maybe they're managing diabetes, maybe they're managing depression, maybe they're managing their HIV care. And we'd have them on a continuum because they will continue to be on that, versus a cascade of care, which ultimately someone would fall off of. We'd get them on and they'd fall off. Hepatitis C is on a cascade. Someone would get on here, we would start with being undiagnosed, move to a place of diagnosis, we'd stage them, treat them, cure them, and we'd hopefully maintain wellness, and hopefully they never get back on this cascade. And if you haven't noticed, this cascade on the bottom here is ultimately how these modules flow. Module 2 will focus on diagnosis. Module 3 is vaccination, which is in between here. Module 4 is staging, 5 is treatment, 6 is cure, 7 is wellness. And so I'm asking you to integrate a cascade of care into your system that may look like a continuum. And that's really challenging, but it is absolutely possible. And so I'm hoping that the information that you've just received on hepatitis C virulence and the impact of hepatitis C on our communities and the differences with hepatitis B and A and HIV will help you understand the opportunities that you might have to integrate Hep C services into your programs. So we're going to pause here. Please make sure to complete your pre-test or post-test questions, and we'll see you at 1B.